Carol Anne Riddell, and this is Science and You. We're here at Mount Sinai with a show you and the women in your life will want to pay close attention to. Over the next half hour, we'll get you up to speed on some of the most critical issues in women's health today, from major medical breakthroughs to potential health consequences from the cosmetics we use. We begin with Dr. Max Gomez and more on the symptoms women need to be aware of when it comes to heart attacks.
Ask most women what disease they fear most, and chances are they'll say breast cancer. Yet heart disease kills 7 times as many women every year. Just as scary is the fact that women usually don't have the same signs and symptoms of a heart attack as men. Here's what women need to know to protect themselves.
In the middle of the night, I just got up and my heart was pounding. Boom, 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 just like that. And I said, what? You know, I had never had this before. Absolutely the first
What
time.
did you think was happening?
I thought I was dying.
What Marcia Kaplan was feeling was a major heart arrhythmia. The regular beat of her heart had gone haywire. While most arrhythmias and their minor cousins, palpitations, are benign, they can be troubling and are more common in women.
The palpitations can actually be the precursor to a very bad thing coming along. So it does not, it's not something that can be easily ignored. With women, they are more common. And to some degree, that's because the hormone changes that we have are a little more complex and produce changes that are sometimes perceived. And then other times it's just because our body habitus, for some of the women, is quite petite. And so
they're just smaller.
Correct, so that the reverberations that come from even just a single skip beat can be felt much more easily.
The good news is that arrhythmias are easily diagnosed with a variety of EKG recording devices. There are some medications for arrhythmias, but they often have significant side effects.
I would feel sort of tired and a little unsteady on my feet. I was always afraid that I was going to faint.
That's why many arrhythmias end up being treated with a technique called electrophysiological ablation, where the source of the abnormal heart rhythm is destroyed, which can be especially important for young women.
Once the woman is pregnant, treating anything is much more difficult. And there's even some of the dangerous rhythms are more likely to happen and cause sudden death during pregnancy. So you really want to screen the younger woman who has palpitations much more aggressively than a young man.
But far more common and dangerous than rhythm problems is an actual heart attack and the way many physicians respond to women with heart symptoms.
I was being completely ignored, that I was being, that the suggestion was that I was more of an anxiety-ridden person, and that there was no reality behind what I was suggesting.
Judy Fine was a walking bundle of heart risk factors. Father and grandfather both had heart attacks in their early 50s. She was a smoker, had gone through early menopause, and her cholesterol was high. Still, her male doctor was annoyed when she started having unusual symptoms. Judy insisted on going to the hospital.
We went into the triage center where they interview you, and the woman said, "What's your name?" I said, "My name is Judy," and I had a heart attack on the spot.
Judy's new cardiologist, Dr. Marianne McLaughlin, says that even though heart disease is the #1 killer of women, many women and even their doctors miss the signs of a heart attack because it's not the classic Hollywood version of an older man's heart attack.
Women may say, I am just so tired, I can't do anything for the last couple of days, I just can't move. It's a sudden onset of extreme fatigue, almost like having mononucleosis. It's a very fatiguing experience. And then sometimes it's associated with some nausea, some indigestion, some sweating. Importantly, pain between the shoulder blades walking up a hill can be heart attack. Jaw pain, tooth pain.
The key to preventing heart disease is mostly similar to what it is with men. Know your blood pressure and cholesterol numbers and lower them if they're high. Don't smoke. Get some regular exercise. Maintain a healthy weight. Avoid sugary foods. And especially important is to keep your waist under 35 inches. But women also have some unique risk factors.
Depression and rheumatologic diseases. So depression has been linked to not only be associated with heart disease, but to predict those who will develop heart disease. Number 2 is any kind of rheumatologic disorder, such as rheumatoid arthritis or lupus, which is more common in women, causes more inflammation. That inflammation has now been linked to increased risks of heart attacks.
Women with any of those risk factors need to be especially aggressive in controlling their blood pressure, their cholesterol, their blood sugar. But perhaps the most important factor of all is to pay attention to what your body is telling you. You know your body best. And if something just doesn't feel right, don't let a doctor tell you that it's all in your head. Insist on getting checked out. For Science and You, I'm Dr. Max Gomez.
You may not realize it, but women are more prone to having strokes than men. Fortunately, there are many advancements in prevention, treatment, and rehabilitation. Mike Gilliam has the details.
Each year, more than 800,000 people suffer strokes in the United States, and women are more prone to having them than men. But there have been advances in treatment. To learn more, we've come to New York Presbyterian Columbia University Medical Center to talk to an expert.
Stroke is damage to the brain that's caused by a blood vessel injury of some sort. So it could be either a blockage of a blood vessel or it could be a rupture of a blood vessel leading to a hemorrhage in the brain.
Dr. Elkins says the risk of stroke increases with age, so older women are more susceptible to them. And young women have a higher risk of stroke than young men.
That probably reflects hormonal factors, including pregnancy. So pregnancy is one high-risk condition for stroke.
What are some of the other high-risk conditions?
Major risk factors for stroke include high blood pressure, diabetes, smoking, heart disease, particularly a condition called atrial fibrillation, which is when the heart beats irregularly. And that actually occurs commonly in women also as they age. So in older women, we do see this atrial fibrillation. That can be a major cause of stroke.
According to Elkins, progress has been made over the last couple of years when it comes to treating strokes. But stroke is still the 5th leading cause of death. Even if a person survives, the effects can be devastating.
It can leave people paralyzed, unable to speak, homebound, unable to work.
But not all strokes are that bad, and a patient can recover from a stroke. And Elkins says advancements over the last few years, and especially the last year, have helped to prevent stroke and have led to better recoveries.
We've learned how to use medications more effectively to prevent strokes by controlling the risk factors like high blood pressure, cholesterol levels, diabetes, and so forth. We've also developed in the last decade or two good ways to treat people when they come into the hospital with a stroke. And some of the major advances have actually occurred just within the past year, so that's been very exciting. And then we're just beginning now to also develop therapies to help people recover after stroke too.
When it comes to treatment, one major new advancement involves the use of mechanical devices called stent retrievers to go in and remove the clot from the brain.
The way this procedure is done is by introducing a catheter into the bloodstream, threading it up into the brain, and then deploying a stent, which is like a metal tube, into the blood vessel. It opens up within the blood vessel, essentially pushing the wall of the blood vessel and the clot that's there against the wall of the blood vessel. And then it can be pulled out. And when they're pulled out, they bring the clot with them and remove it from the brain.
Specialists are also using new powerful drugs called TPAs to blast away clots.
It's essentially a clot-busting drug. It works by activating the body's own clot-busting system to break apart clots that form in the brain.
But even with major advancements in treatment, it's imperative that stroke victims get to the hospital quickly.
We know that time is brain, meaning that the longer you wait, the more damage to the brain will occur.
In recent years, patients had about 3 hours to get treatment if they were to have the best possible outcomes after suffering a stroke. That window has now been extended to up to 6 hours, but the sooner a patient gets care, the better. So it's imperative to know the symptoms of stroke. They can include something called the suddens.
An important feature of a stroke is often that it is a sudden event. So it happens very quickly, and that's often, so somebody's walking down the street, one moment they're fine, the next moment they can't speak or they're weak on one side of the body. Sometimes we use a simple acronym to help people remember, and it's FAST, F-A-S-T. Face weakness, face drooping, for example. Arm weakness, difficulty lifting up the arm. Speech difficulty, so the S is for speech difficulty, having trouble speaking, slurring of the speech, or difficulty understanding what other people are saying. FAS, T is time. Then it's time to call 911.
So that's very important information. If you see the signs of a stroke, get help immediately. That alone could help lead to a good recovery. I'm Mike Gilliam for Science and You.
Ovarian cancer has been called the silent killer because it often goes undetected until a late stage. In our next story, Vianora Vinca shows us how more women are saving their lives, empowering themselves with knowledge, and fighting this dreaded disease.
Broadway star Magalie Laguerre-Wilkinson felt strongly about raising awareness about ovarian cancer in a public service announcement after her own diagnosis.
The one great thing about where I am is that I caught it early enough. I was confused because it did not run in my family. I had never heard about it before. I was 34, African American, healthy, active, and I was now being diagnosed with ovarian cancer.
Her empowering message is that the disease does not have to be the silent killer it's been labeled.
Ovarian cancer has been traditionally called a silent cancer or a cancer that whispers, and what that means is that the symptoms are fairly vague and very commonplace for many women.
According to the American Cancer Society, the commonplace symptoms of early ovarian cancer are bloating, feeling full quickly, pelvic or abdominal pain, and increased urinary frequency. While annual pelvic exams do in some cases detect tumors, making regular OBGYN visits all the more important, there are no medical screenings like blood tests or sonograms to detect early ovarian cancer. Is going to the OBGYN annually enough to detect early stages of ovarian cancer?
We actually don't have any way to detect early ovarian cancer currently. Most ovarian cancers are detected in what we call stage 3 ovary cancer, which is when the disease has spread from the pelvis, from the ovaries, outside into the abdomen. That's when the symptoms become dramatic enough that women will present to their doctors, and the doctors will then order imaging, and that is typically how it is diagnosed.
The American Cancer Society estimates that about 22,000 women are diagnosed with ovarian cancer each year, and 15,000 die from it. But when caught early, the 5-year survival rate has now reached 90%. Medical experts say all women are at risk, and some groups are more at risk than others: women of Ashkenazi Jewish descent, those who are overweight, and women over 65. Also, the National Ovarian Cancer Coalition says that 1 in 7 women get the disease due to a family history of certain cancers.
I think one of the most important things is family history, and as a physician talking to women every day about their family history, we are able to triage which women should be concerned about possible genetic risk of cancer versus those that have less of a risk.
Some of the related cancers to look out for in family history are ovarian, breast, colon, and pancreatic cancers. When these exist on either maternal or paternal side, doctors advise for blood test screening to detect the possible presence of the BRCA1 or BRCA2 gene mutations, known for dramatically increasing the risk for both breast and ovarian cancer.
I was shocked at first when I got the news that I was positive for the BRCA mutation. I didn't think in a million years that it was going to come back positive. It just didn't occur to me. And I had a lot of thinking to do, and I had to come up with a plan.
Sarah's plan became undergoing the drastic preventive surgery of ovaries removal and double mastectomy, rather than medical surveillance for possible onset of cancer. According to the National Cancer Institute, preventive surgery reduces ovarian cancer risk by about 90%. It was not an easy decision for Sarah, but an informed one, as she asked 11 other doctors for their opinions.
They all said to me, "You don't have to have the surgery." And I said, "What is the smartest thing for me to do?" And they said, the smartest thing for you to do is to have the surgery. So I went with that. In my gut, I already knew that. I looked at the numbers myself, and that's what I thought. But I was trying to find a doctor to convince me otherwise. I couldn't find that.
Preventive surgery was Sarah's choice and may not be what other women would opt for. But the consensus among OBGYNs is that what all women can do to prevent or stop ovarian cancer is to know their risk and to pay attention to new and persistent symptoms.
There are a lot of women out there who are scared, who are paralyzed by fear. And I would say take the fear and use it as fuel. I absolutely feel empowered doing what I did. I feel like Superwoman. I feel bulletproof.
Vianora Vinca, Science and You.
Thyroid cancer, it is on the rise, and simply being a woman is one of the risk factors. Here's what you need to know. Even though she's a physician herself, thyroid cancer wasn't something entirely on Stacey Chasen's personal health radar. She had no signs or symptoms, but her family history put it front and center.
Within 1 year, my mother had been diagnosed and my mother's brother had been diagnosed. They both had surgery. They had been taken care of well. My family was actually pestering me that I should have an ultrasound completed and take initiative and make sure everything's okay.
Working with her doctor, Dr. Marita Tang of the Mount Sinai Hospital, Stacey had an ultrasound which detected a nodule. Then came surgery.
The result came back as the same type of cancer that my mother had and that my uncle had, which was papillary thyroid carcinoma. So at that time, Dr. Tang removed my entire thyroid.
Stacey is now doing well. Her cancer was caught early. As Dr. Tang explains, the disease can be very treatable.
The two most common types, which are called papillary and follicular, are both very, very treatable and very curable. So the cure rate is in the 90%, even in some series in the high 90%, even close to 100%. It is always better to catch it early, though the cure rate of even somewhat more advanced cancers is still quite high.
According to the American Cancer Society, thyroid cancer is the most rapidly increasing cancer in the U.S. Estimates for 2015 are about 62,450 new cases of thyroid cancer, more than 47,000 in women. So what's behind the increase? Perhaps better screening.
Many people believe that the reason why the incidence of thyroid cancer is increasing is actually because we're detecting it with greater efficiency.
Here are some of the risk factors from the American Cancer Society. Gender. Thyroid cancers are more common in women. Age. Women are most likely to get it in their 40s or 50s. Men more likely in their 60s or 70s. A diet low in iodine, though that's rare in the United States. Radiation exposure. The risk is highest if exposure occurs in childhood. Family history. Having a parent, brother, sister, or child with thyroid cancer increases your risk, and certain genetic conditions. Dr. Tang explains thyroid nodules are common, especially in women, but the proportion of those that are actually cancer is small, and there is a simple way to screen yourself right at home.
The thyroid is located in the middle of the neck. It's below where you feel your Adam's apple. Certainly you can just feel that area from time to time, but another easy way to do it is to just look in the mirror, focused on that area of your neck, and take a small sip of water, and while still looking at your reflection, take a swallow, and you'll see your Adam's apple rise, but also below it, if you see any sort of lump that's on one side that's not the other, or something doesn't look quite symmetric, or there's a little roundness or something protruding, then it might be a good reason to get checked out and just see your primary care doctor.
What would your advice be to other women?
Knowledge is power. I've learned a lot about that over the last year and a half. Knowledge is power, and the earlier you get treatment, the more likely you are not to have any complications.
Breast cancer is a disease many women fear, and for those facing it, losing their hair during chemo can be particularly crushing. But some patients have been able to keep their hair with a technique called cold cap therapy. Donna Hanover explains.
For many women, the anguish of a cancer diagnosis is worsened tremendously by the emotional pain from losing their hair during chemotherapy. But here at the Weill Cornell Breast Center, some patients are able to use cold caps to reduce hair loss.
Hair loss is one of the most dreaded and feared side effects of chemotherapy. Losing one's hair makes one feel sick. Other people treat a woman as if she's sick.
Dr. Tessa Sigler says scalp cooling often reduces hair loss. Patients need to wear the cold caps for about an hour before each chemo session starts, all through the hours of chemo, and for some time afterwards.
It's thought to work by two main mechanisms. The one is that the very cold temperatures cause the blood vessels in the scalp to constrict, and thereby the chemotherapy isn't able to penetrate the scalp as well. The other mechanism is that the cold temperatures arrest the hair follicles. In other words, it puts the hair follicles to sleep, and thereby the hair follicles aren't as well able to take up the chemotherapy.
Carolyn Dempsey got a diagnosis of breast cancer in 2013. She first heard about cold caps from a friend in Texas who used the penguin cap.
I was amazed, and when she told me, I wanted every detail about how does this work? Where do you get these caps? You have to rent the caps from a company in England. It's very expensive. You get them, you have to keep them in your freezer, and then bring them on dry ice to your infusion site. It's very, very cold. Patients have to wear moleskin so they don't get frostbite on their scalps.
And patients need friends or family to monitor the temperature of the penguin caps and change them out every 20 or 30 minutes. Weill Cornell has encouraged use of the cold caps, and the Rapunzel Project donated a huge room-size freezer. Weill Cornell also recently helped run a medical trial of the Swedish DignaCap, which has an attached cooling system and a cap that doesn't need to be changed. Carolyn Dempsey was lucky enough to get into the trial.
It works phenomenally well and is much more comfortable and less cumbersome than the penguin caps.
The results of the trial have been presented, and there is eager anticipation of FDA approval. That might also trigger insurance coverage for DignaCap. In all cold cap therapy, one major question is risk.
The biggest medical concern about cold caps is the idea that maybe we're not protecting those scalp cells from developing cancer in the future. The data from Europe has been very reassuring to date. Scalp metastases in general are incredibly rare. So we tell our patients that it is a theoretical risk, but we think it is very, very minimal.
Dr. Sigler says scalp cooling is best suited to patients being treated for solid tumors rather than blood cancers. In Europe, it's used not just for breast cancers, but also for tumors in other parts of the body. She warns that even with cold cap therapy, there is usually some thinning of the hair.
Which we like because it means that the chemotherapy is penetrating the scalp to some extent.
As for the benefits, Carolyn says she wants to spread the word.
I can't tell you how many phone calls I get from people in New Jersey. So many people would want this. I was resigned that I was going to lose my hair. Once I was able to keep my hair, I felt a sense of empowerment. You know, it felt stronger than the cancer. And it was, I'd say, invaluable to my children as well, because they didn't see mommy as being so sick.
What did your children think about the pictures of you in the helmet?
And they thought I looked like a pilot. They thought it looked like mommy was flying a plane. They tried it on themselves at home and took pictures of themselves with the cap on.
My patients who've used the cold caps have all been very pleased that they've done it. It's allowed them to protect their privacy, and I think has made a big difference in how they've managed and their quality of life.
By being able to maintain your hair, you look in the mirror and you get to see yourself and not see your sickness.
Carolyn and other cold cap users want people to know that as devastating as a cancer diagnosis is, the ability to use the cold cap technology to reduce hair loss can be one way to fight back. I'm Donna Hanover for Science and You.
Doctors expect that if there is FDA approval, the DignaCap will be much in demand by cancer patients around the country. Finally today, bronchitis, asthma, and skin rashes. They are all potential reactions to chemicals, but not necessarily the chemicals under your sink. They could be caused by what you're putting on your face. Magalie Laguerre-Wilkinson has more on what we need to know in our daily makeup routine.
Are you conscious of the type of makeup that you put on your face?
Now that you mention it, not really.
Do you think about how makeup is made?
Yeah, because it's like, oh, this is really shiny, but why?
I've had friends that have worn makeup and gotten really bad breakouts. Some of them have gotten burns from certain types of masks they wear.
Applying makeup is a daily task for most women. Lips, eyes, face, and neck. But staying beautiful has its concerns depending on what you use and how you use it. Monona Russell is a chemist, theatrical consultant to a host of Broadway shows, and an author who writes extensively on health hazards in the arts. Her book, Pick Your Poison, cautions that when it comes to makeup, there are pitfalls in the pursuit of perfection.
What is in our makeup?
Well, they're all the same chemicals you'd find in industry. There are toxic minerals, including talc, titanium dioxide, kaolin. There's every kind of organic chemical. There are preservatives.
So in your book, Pick Your Poison, you say that all natural cosmetic labels don't actually mean that they're all natural. Why?
It's amazing where this came up, and now people just think if it's natural, it's going to be safe. My gosh, the most toxic chemicals we know come from Mother Nature. Most of the allergens have a natural background. It's pollens and pet dander and things like that people are allergic to. Mother Nature doesn't love you.
Monona points out one of the worst makeup health hazards comes about when we inhale things like sprays and powders.
You're talking about airbrushed makeup. That's like the new thing now.
I know.
And it looks beautiful, I have to admit.
It sure does.
But it's a safety hazard, you're saying, a health hazard, I should say.
Absolutely. Titanium dioxide is the major base in almost all makeup.
It's that component.
It's a mineral component. Mm-hmm. It's been a part of makeup for a long, long, long time. But it is now listed as a lung carcinogen by inhalation. And the smaller the particles, the more dangerous. Anytime that you can use a different type of application, anytime that you can use a liquid application or a sponge type makeup or any of those kinds, that is far better for you.
Use makeup wisely and practice good hygiene. Never sleep in your makeup and don't share makeup under any circumstances. Always use as directed and don't put anything on your face that isn't really makeup. Avoid inhaling or ingesting makeup designed for external use. And throw away all the old stuff because preservatives don't last forever.
Is it really hazardous when we use makeup beyond its expiration date?
There's a period of time when that preservative will no longer work. And then it's just a nice little petri dish waiting there for something to get started.
No one is saying to ditch the makeup, but with a little common sense, you can still look your best. I'm Magalie Laguerre-Wilkinson for Science and You.
That's our show for today. Join us next month for an in-depth look at pain, how we experience it, treat it, and live our lives while managing it. I'm Anne Riddell. Thanks for joining us for Science and You.